Geneva. My name is Alexandra Kuzmanovic, and I'm pleasure to host this weekly live Q&A about COVID-19 with Dr. Maria Van Kerkhove and Dr. Mike Ryan, who is joining us today remotely. Today is also World Humanitarian Day, and we are celebrating real-life heroes. Maria and Mike are some of those real-life heroes who've been saving lives in the field and fighting different disease outbreaks for years, working for WHO and other institutions. Good afternoon, Maria. Good afternoon, Mike. Thank you for your time today to respond questions from public about COVID-19. But just to reflect on the celebration of real-life heroes and your field missions, can you tell us what are your main experiences in career in saving lives and fighting diseases? Dr. Mike Ryan, are you there? Do you hear us?
I think I do. Can you hear me?
Yes. Thank you. Welcome.
Thank you. Thank you. No, yeah, I think we see heroes in every walk of life, and I've spent more than 25 years at this now, and every single time I've been in the field, I've seen people old and young just be heroes in humanitarian and in epidemic response. And it's sometimes it's never, in my experience, it's never the loud, the brash ones. It's very often the quiet people who people don't notice that do the most good. Just simple, ordinary people who do extraordinary things in the face of a crisis to help themselves, to help their families, to help their communities. And I think I've witnessed in almost every response, from youth groups in Gulu and Ebola to the most amazing people in Syria, in Iraq, and in other places. So yes, and crisis response needs heroes. But those heroes are very often not the ones we recognize, not the ones we see on TV. They're the ordinary people, the ordinary young and old people who do extraordinary things to help them, their own communities.
Thank you, Dr. Mike. Maria, any reflection from your side and from your field experiences and missions in previous years?
I think just to reiterate what Mike says is that there's so many frontline workers and so many unsung heroes, that are really doing the work. Some of my fondest memories of, you're seeing a picture of me in very heavily pregnant in Kuwait, working on a MERS sero survey with incredible people. And some of my fondest memories are in Cambodia and working with the Institut Pasteur of Cambodia and people from the Ministries of Agriculture and Ministry of Health and village leaders and village animal health workers. They taught me everything I know about outbreak investigation in all reality, in terms of working with communities and engaging communities and working in this One Health approach, which is now called a One Health approach. Before, we didn't even have that phrase. Just collaborative, constructive, friendly. I miss my time in the field. I love working at WHO. I love working in headquarters, but I do miss the field. I do miss being with people. So from field missions in Cambodia on avian influenza and dengue, to working in Brazil on Zika, to working across the Middle East on MERS, I am incredibly fortunate to have worked with so many incredible people on the ground. But as Mike said, there's the people that aren't on TV, are really the heroes. And I think, as you've pointed out, on this World Humanitarian Day, it's not just, the health workers. The healthcare workers are our heroes. There are also incredible heroes working in different frontline aspects of this response and many other infectious disease and humanitarian responses.
Can we mention and reflect maybe on different roles and different humanitarians in the field fighting COVID, but also Ebola, polio, cholera, and other disease outbreaks? We know that some of them are really working in very difficult conditions, even in conflict areas. So maybe we can reflect a bit on their roles and how they look, their day looks like.
Yeah, Mike, do you want to start on that?
Yeah, no, and I think it's important. Sorry about that. Is that okay? Can you hear me? I think I've lost you.
We can hear
We
you.
can hear you well.
Yeah. Okay. Okay. If you can hear me, I'll start. I just lost. I can't see you. I can see two of me now. The what was our question? Oh, yeah, the other types of events. I think it's important for us to reflect on the fact that when we look at conflict and we look at natural disasters and we look at epidemics, there's very unfortunate coalescence of all of that. Increasingly, we're seeing high impact epidemics occur in areas of conflict and fragility. 70% of the big epidemics that we respond to around the world, we respond to in about 30 countries. Those countries affected by fragility, conflict, and vulnerability. Those are the same countries bearing the impact of climate stress, climate change, population movement. So we're seeing a very unfortunate alignment of risks and really affecting some populations in a much more profound way than in other places in the world. And that puts both local health authorities, but also UN and NGO workers under tremendous strain, because one week they're responding to cholera, the next week they're or to flooding, the next week they're responding to a cholera outbreak because of the flooding. 6 months later, there's drought, and there's famine, nutritional crisis. Then there's more rain, and then you get an outbreak of malaria or yellow fever or dengue, and one thing leads to another. And we are in that era when these risks and these disasters are linked, and everything on our planet is now linked in such a way that a disaster in one area can just create more disasters, or those disasters can extend to other areas. And in the midst of all that, there are hundreds of thousands of frontline workers, both governments, local NGOs, international NGOs, UN workers, who work tirelessly in every walk of life, be it water and sanitation engineers to people who do demining to allow people to go back and carry out agriculture. There are people who work on nutrition. They're particular heroes of mine. People who work on education, rebuilding education systems. So there are everyday heroes in every walk of life in responding to these epidemics. Because something like cholera, it's like COVID. It's not just, it's about education. It's about access. It's about poverty. It's about having enough resources to access the health system. It's about fairness. It's not just about the virus. And that's the same for cholera. That's the same in every epidemic. Epidemics expose the inconsistencies and the inequalities and the inequities and the injustice in our societies, because it is those who are poorest and have least are most affected. And exactly the same happening today with COVID-19. No different than I've experienced for a quarter of a century. It's more obvious, it's more brutal, it's more cruel, because it's seen everywhere in the world at the same time. But populations around the world, particularly in these fragile countries, have been experiencing epidemics this bad and worse with other diseases for decades. Sometimes we don't give it that because it's far away. Now it's everywhere, and we see what happens when contagion and infectious disease enters our society, when we don't have a vaccine, we don't have adequate therapy, we don't have adequate public health surveillance. And the fear and the uncertainty and the anger that generates. But we need to think about people who live with that every single day of their lives. And there are people on this planet who live with that and have lived with that their whole lives. And I think it's time for us to put an end to that. It's time for us to recognize we need a different planet. And we need to celebrate those heroes who work every day to fight for social justice, for climate justice, for health justice.
Maria, please.
Yeah, just to add also that, as Mike is saying, many people are dealing with something like this, like COVID, and even worse, and a combination of factors every day, and are dealing with this every day. We have our health workers who are, first and foremost, putting themselves at risk to care for patients of many different infectious diseases, dealing with trauma from other types of events, from natural disasters. But there are a lot of non-health essential workers that are out there that are also heroes as well. And these are people that keep us alive and keep our services going. These are people in food production that make sure that electricity still flows and that water still runs, and that sell us the food and, you know, run grocery stores, and keep services ongoing. These are people who deliver vaccinations, life-saving vaccinations to people of all ages that need those vaccinations. This is law enforcement. You know, these are people that pick up trash and rubbish and make sure that, you know, life continues. And they're also heroes in this, and they're heroes that go to work and keep our societies running. And so we just want to pay tribute to them as well, because it's not all of us have a role to play. All of us have to be part of this. And I think, as Mike pointed out, many people are dealing with this every day, day in and day out. And the rest of the world is really seeing just a glimpse of how difficult that this is that many people live with. So we thank, you know, all essential workers who are fighting COVID, who are helping keep systems running, help keeping us all alive. So we thank you.
Thank you, Maria. Thank you, Mike. One of those roles and responders in the chain of activities we need to do to suppress virus are contact tracers. And we've been talking a lot about contact tracing, but some of our viewers are already asking if we can explain why are we doing contact tracing and how contact tracing is helping us suppress the virus.
So thanks, Alex. I'll begin. So contact tracing is one of the elements that's really required to help us break chains of transmission, is what we call break chains of transmission. And what we mean by that is each case, when you identify a case of an infectious disease like COVID, what you have to do is you have to isolate that case, which means take them away and put them in a place where they don't have access to other people. They're cared for, they get medical care, they still have communication with their families, but they're isolated. You identify all of the contacts that come in contact with that individual. We have definitions for what that means. It's at least 15 minutes with someone, face-to-face contact. It may be someone that has direct contact with someone. You identify those contacts and you put them in quarantine, what we call quarantine. Quarantine can take place in a facility outside of your home, where they are cared for, where they're provided meals, where they're provided safety and security, or it could take place at home. And that basically means that you need to be away from other people for 14 days. And the 14 days is the time that it takes between exposure and the longest time period of when you develop symptoms. And we put you in quarantine. And contact tracing is so important because it prevents you from coming in contact with someone else should you be infected. And so if you are a contact of someone, it is very important that you listen to the authorities who are trying to reach you to say you may be a contact, we may need to follow you up, you may need to be in quarantine for 14 days, and this is what it means. But you can play an active role in being part of that. So in many countries right now where they're listing contacts that you need, if you go someplace, you may have to give your name. Please give your real name. And please give real contact information so that they can find you and say you may be a contact and you may need to be in quarantine for 14 days. So it's a really critical function as it relates to breaking chains of transmission.
So that we can find out where the virus is and stop it from spreading, right?
Yes.
Some viewers, Mike, actually, would you like to add something?
No, just to say that we've controlled countless number of Ebola outbreaks and other events using contact tracing. It's not used for every infectious disease, especially where you have good treatment or you have vaccines. You can avoid having to do contact tracing because it is complicated. It's very easy as a concept, but it's very difficult to implement because, number one, you need a good public health system to do it, and two, you need a community that accepts and participates actively in the process. And both of those are not a given in many situations. And all countries, to an extent, have struggled with both of those concepts. But it is, as Maria said, hugely important. You're trying to break the chain of transmission. The virus cannot live outside the human body for a very short time. It needs to find a human host in order to reproduce itself. So if you can prevent the virus jumping from one person to the next, then you can stop the chains of transmission. A contact of a case is someone who's already had enough contact with the case to possibly be infected. And a contact is someone who may become sick with the virus. What you do by isolating contacts or quarantining contacts is that you ask those contacts to stay distant from other people for that 14 days while monitoring that individual. There are two benefits to that. One is the individual under observation can access healthcare quickly if they get sick. And number two, if that person does get sick, they have not already passed the disease on to somebody else, and you're breaking the chain of transmission. So that contact, and this is probably the central thing for the next 6 months. We're doing lots of stuff on physical distancing. It's fantastic, and congratulations to everyone out there who's working to reduce their exposure and reduce exposure to others. But at its center, the central pillar of controlling this disease, if we want to go back to school, if we want to go back to work, if we want our societies to return to normal, we have to put a greater focus on identifying suspect cases, testing those cases, identifying each and every contact of that case, and asking those cases to quarantine for 14 days. If that happens tomorrow, if we could do that tomorrow, we would drive infection rates right down, and we would get to a scenario in which schools can open, in which society can return to normal. It is the weakness in that system that is causing a lot of trouble worldwide right now. Those systems are just not good enough. They're not invested in enough. They're not committed to enough by governments. And equally, on the other side, in terms of communities and individuals, human behavior is human behavior. The vast majority of people are complying with the requests of government, but some are not. If you put bad surveillance and bad contact tracing together with less than perfect community participation in risk reduction, then you have a very, very dangerous mix, which allows the virus to jump back up. And we're seeing that happen in a number of countries.
Thank you, Mike. I would just like to invite our viewers who maybe just joined the program to ask their questions through comment section or on Twitter to use hashtag AskWHO. Meanwhile, we have more questions that came as well on contact tracing. Is how can people participate in contact tracing unless they are required to the places where they go? Is there something that they can do proactively?
Yeah, there's a couple of things that people can do, that everybody can do. First is in countries where you have been identified as a contact, you may be called. You may be called by a health professional. Please answer the call, and they will give you instructions about what you can do and how you can quarantine yourself, if that can be done at home, and what it means for them to follow you up, and what type of care that you may need to seek. The other thing is that there are a number of apps that have been developed for contact tracing. I have one that I participate in here in Switzerland, where I've downloaded on my phone, and I've agreed to participate in this, where it will tell me if I have been in close proximity to somebody who has been identified as a contact. That is a choice that I have made to be able to use that app. So there are a number of countries that are using these types of apps, and you can choose to participate in something like that, and that could be quite helpful. But most importantly, I think that if you decide to attend certain locations, and I think many of your viewers may have heard us talk about individual risk and be your own risk manager, about taking decisions about where you go and how you live your daily life. If you are participating in events that may put you in close proximity to one another, you may be asked to give your name, you may be asked to give your phone number. Please do so. That would be very helpful should there be an event there. And so that will help authorities quickly identify the cases and the contacts so that you could be put in quarantine and that you can receive the care that you need to break those chains of transmission.
Maria, you mentioned you agreed to participate in this app and to share your information. So some people have concerns about sharing their data. So can we explain how these data are used so that people understand why is it important actually that we share this type of data with our communities?
Yeah, so I can start, and Mike, I'm sure you will want to add to this. That many of these apps, they're using like a Bluetooth technology. And so what I, in the app that I'm talking about, agree to give the location of my phone so they can see where I am. This helps make some connections between where I have been and where a case may be. And that helps make those links. The data that is used, it's under specific use for contact tracing purposes. It's not sold to other individuals. They're not sharing that information. But it is important to understand what you are agreeing to, and that people have the choice to agree to that or not. But I do want to say that these apps are a supplement to what contact tracing is, because most of what contact tracing is done by people, done by live human beings who are making connections, making phone calls, sometimes spending time. We call these boots on the ground, shoe leather epidemiologists, which essentially means walking around. And that came from, the John Snow days of looking at the cholera outbreaks in London, literally walking around and finding, where the contacts are of known cases. And these apps can help, but they can't supplement, they can't take the role of real live human beings who are doing contact tracing. And you'll probably have heard in a number of countries the number of contact tracers that are being recruited to support the efforts to break these chains of transmission in many countries are in the thousands or tens of thousands. And so we really do need people that help, and that people make the connection. So even if you are identified in an app, you still need to talk to a human being and say, okay, what does this mean? Where can I do my quarantine? What type of care do I need? If I develop symptoms, how can I get a test? If I develop symptoms, do I need to seek medical care? And you do need that interaction with a live human being.
Thank you, Maria. Mike, would you like to add something to this, please?
Well, I think we're unfortunately faced with a very stark choice as a society right now. We are either going to see the disease jump back and face the possibility of further lockdowns that none of us want, and we don't believe are the most effective way, frankly, of dealing with this disease right now. But what a lockdown effectively does is separate everybody from everybody else. Everyone in society has to separate from everybody else because we don't know where the virus is. So we separate everybody. The beauty of contact tracing and the beauty of finding the contacts is that you do know who's at risk, and you ask those individuals to quarantine themselves, and the rest of society can go about its business. And that is a sacrifice that individual makes on behalf of society in order for all of society to move ahead. And testing, tracing, quarantine, this is a hugely important part of the next phase of this response. And we've seen countries who've really focused on that, and they've managed. Yes, countries have had flare-ups, and a number of countries have had flare-ups. The flare-up is not the problem. The real test of a country is how they react to those flare-ups. Can they identify clusters quickly? Can they identify the cases and the clusters and the contacts of those cases? Can they quarantine those contacts? Can they support those contacts when they're in quarantine? Because by doing that, the rest of society can get on with its reasonably normal life. I would contend quite strongly that all over the world, we have not invested enough in test, trace, isolate, quarantine process. We are bleeding trillions of dollars in fiscal stimulus. We are pumping huge amounts of money into mitigating the economic impacts of this virus. But we have yet not invested enough collectively in the public health architecture, the public health workforce, the testing, the tracing, the quarantine, that process. Because every dollar spent on that saves so much in terms of economic damage down the line. And I think we haven't got that arithmetic right yet. And I believe we haven't invested enough in that side of the equation. And we haven't invested enough in community education and community participation. If people don't participate and don't, as Maria said, want to leave their real name, if they don't want to give their full contact details, they obviously have some fear of how those details are going to be used. That's a trust issue. And governments have to work hard to build trust with communities in order that people are comfortable giving their personal details in order to be contacts and to be traced. You have to be able to offer a service to people when they agree to be isolated or quarantined for 14 days. So I do think there's a big choice here for us all to make. We have not, and I say this, and I'm sure lots of people are going to jump on this statement, but we have not invested enough in testing, tracing, isolating, and quarantining as a major pillar of this response. And if we don't get serious about this, I'm afraid we're going to face the prospect of further lockdown.
Can I add to that? Because I fully agree with what Mike says, obviously, but I think that is our way out of this. our way out of this is the investment in the public health infrastructure. And I think one of the things the world has learned from is, and all countries are learning from, is those countries that have had direct experience with infectious disease outbreaks where you need to do active case finding, contact tracing, increasing your workforce. Those countries have seen more success in reducing transmission, suppressing transmission, breaking chains of transmission, and saving lives, and really preventing this virus, which likes people, it needs people. This virus operates in clusters. It needs people to circulate. And what we are seeing consistently across countries is that it forms clusters, and it forms these super spreading events, these outbreaks. And we are giving this virus an opportunity to do that by coming together, by being in close proximity with one another, being in enclosed settings, crowded spaces, not physical distancing, poor ventilation. We are allowing the virus to be able to pass. But we are smarter than the virus. We are smarter than the virus. We have tools right now that can break chains of transmission, and contact tracing is part of that. And so having huge stimulus packages, trillions and trillions of dollars to be able to get us out of that. If we could invest in our public health infrastructure, which is much lower in cost, it will be beneficial not only to COVID, but the next infectious disease, for influenza, for other infectious diseases where these types of activities are really critical. The activities themselves that we need to do are very clear. It's the implementation that is hard. And I think even in countries that are breaking chains of transmission, getting these clusters under control, they've been creative. And so there is no one size fits all, no one solution to how to do this, how to implement this. But we are seeing countries that are being very creative. And I want to bring young people into this because we are seeing that there is a little bit of a shift right now in the number of cases that we are seeing in younger age groups. And I think this is being driven by the fact that some societies are opening up and many people are going about their lives, and younger adults are going about their lives, and they're coming into contact with others. We've seen outbreaks in nightclubs and in entertainment types of situations, and we're seeing younger people get infected. And so everybody has a role to play. So if you are participating, and you can, participate in contact tracing, if you feel comfortable using that app, if you have that trust, do that, and that can help us. But everybody has a role to play.
Thank you very much, Maria. Our viewers are asking a lot of follow-up questions, so okay. I'll try to pass some of those now. One is coming from our Periscope viewer. Why do some countries show very low death rates after the first wave of COVID-19? Are there any linkages to the tools you just mentioned, that if we test and isolate contacts earlier, that we can also treat patients better?
Yes, so there's a couple of reasons, I think, why we see differences in mortality rates across different countries. First of all, in some countries, the virus has caused outbreaks in younger age groups. So I give the example of the Republic of Korea and South Korea, where initially they had outbreaks among religious groups and churches, and that tended to be a younger population. In Japan, for example, many of those outbreaks and clusters didn't enter into long-term living facilities, for example, where you have older people that live, people who have underlying conditions, who are at a higher risk of developing severe disease and die. So if the virus doesn't have an opportunity to enter older populations or enter vulnerable settings, then there's a greater likelihood that you won't see as much death. In some countries, we do see earlier case detection. So if you have active case finding, you have earlier case detection. If you have contacts that are being followed, if they're already in quarantine, they can prevent the virus from transmitting. But even if they develop symptoms, they could seek care earlier. So if you get early care, we know care with oxygen support. If somebody develops severe disease or critical disease requiring oxygen or ventilatory support, that saves lives. We know that using dexamethasone among the most severe patients, that can save lives. And so I think there's a lot of reasons why we are seeing differences in mortality. But a lot of it has to do with who is getting infected. We do know right now that people who are older, people who are over the age of 60, people who have underlying medical conditions like heart conditions, chronic respiratory disease, obesity, diabetes, cancer, they have a higher risk of developing severe disease and death. So if we could prevent infection in people who are of a vulnerable group, we could prevent more deaths. So I think there's a number of reasons why we see differences in mortality, but we do need to be careful about making direct comparisons because there's so many different factors.
Thank you very much, Maria. Here's a question for you, Dr. Mike Ryan, from our Twitter viewer, who is asking Dr. Ryan, is it better for every child to be tested for COVID-19 before they start school? You spoke about reopening schools a lot in previous weeks, so I think this question is coming as a follow-up to your previous responses.
Good, thanks. Just to add to the previous points by Maria in terms of why the death or the severity profile is different, and I agree with everything that Maria said. I think there is a need, as we move forward now, to be really careful about how we protect and shield those vulnerable populations, particularly those in long-term care facilities, people in detention centres, in refugee camps, in prison, anywhere where people are pushed into close proximity, and in particular people who have underlying conditions or age-related difficulties. Some countries have done reasonably better because their age profile is younger, but there is a double injustice here and we cannot escape it. It's an uncomfortable truth, but it must be said. There are many, many people in countries, because of poverty, because of their ethnicity, have much higher rates of underlying conditions because they've had historically very poor access to healthcare, very poor access to health education. They're poor, and they've not had access to the same levels of health as the rest of the population. And every country can look to itself and see where those vulnerable people have been and where they exist in society. And the second problem then is they get sicker when this disease comes, and then they don't have access to healthcare as quickly as other people. They don't have insurance, they don't have access, they live in a slum, they don't have access to good healthcare. So very often they're accessing healthcare very late, they're having to pay for that healthcare, they're impoverishing themselves in doing that, and they wait until it's too late. So there are real, I said it in my previous statement, the COVID-19 is exposing huge injustices in the way people's health is protected over their lifespan. And now, even when they get COVID-19, their access to healthcare thereafter. And that's causing a lot of preventable mortality around the world. Access to care and your previous health status and health status around the world is unfortunately very related to your social status, to your financial status, to your access to healthcare. Dr. Tedros speaks all the time about universal health coverage. We need to move to a planet in which access to healthcare is not a privilege, it is a right. Because we are paying a price right now on this planet for healthcare not being a human right. Healthcare is not a commodity. It's not a commodity to be bought and sold. It is a basic human right. And people with poor health status are doing worse in this pandemic. With regards to children and testing, I think and Maria will probably speak to this as well, it's not so much about testing children, it's about having a proper risk management approach in schools, because you could test all the children today in 2 X, and tomorrow 3 or 4 or 5, 10 of them could turn positive and you've missed them. Because most tests right now are just testing for the RNA, for the nucleic acids, and for the presence of the virus in the nasal cavity. If they're positive today, yes, you can remove that person. If they're negative, it doesn't mean anything because that person can become positive within a few days, especially if they've been exposed recently. So yes, testing can be part of the process of return to school, but it's not central. The most important thing for getting back to school is to get the disease down at community level. If disease transmission is low in the community, if surveillance is good in the community, if contact tracing is good in the community, if healthcare is good in the community, then the schools can go back. They're part of society, they're part of communities. It's very difficult to bring schools back in the context of intense community transmission. But even where there's low transmission, bringing schools back requires caution. And I think there are lots and lots of very good ideas out there, and schools are implementing lots of very, very smart practices, including doing partially online face-to-face. They're cohorting kids in classrooms and not moving kids around the school. They're staggering start times and finish times. They're reducing the number of teachers, the number of teachers, the number of pupils that a given teacher teaches in a given day. There are lots of different ways of reducing that contact, separating desks, and in some cases asking children to wear masks where that separation cannot be maintained. So there's and adding extra hand washing facilities, and then doing ongoing surveillance to pick up any children that do become positive and taking the appropriate action. It's complex, but many schools around the world and many school authorities are taking very, very clever, very innovative approaches. But it is a time of worry for parents, because parents are always concerned. I'm a parent myself, and there's nothing more worrying when you're dealing with the health of your children and should you or should you not put your kids back in school, and what are the risks. Parents need to go back to work, kids need to go back to school. We all accept this, but it has to be done in the safest possible way. And that can really only be managed ultimately at local authority level. It can be supported by government, and it should be supported by government. It should be financed, supported by government. But really, this becomes a very local process, because going back to school depends on the local epidemiology, the local transmission, the local profile of schools, the size of schools, the density of schools, the resources that schools have. And again, we're back to this issue of social justice, because it is in the very areas where we see intense transmission that we have schools that are least funded, most overcrowded, with the least number of teachers, and they're the ones that will be most at risk again. So once more, the poor and the excluded and the marginalized are the ones most at risk, even as we go back to school.
Thank you, Mike. We have a lot of questions coming around the 2 weeks quarantine. People are asking how long the virus can last in the body. Then somebody says a person was hospitalized with COVID longer than 2 weeks. So is 2 weeks still a relevant period for a person? Is it enough to be isolated?
Well, there's two things that you're talking about, Alex, and in these questions. Mm-hmm. One is how long with somebody with known infection should be isolated. Mm-hmm. And then the separate question to that is a contact of a person who has been exposed to the virus, but we don't know yet is infected. How long do they need to be quarantined? So those are two separate things. We know that people who are infected with the virus can live in the body for quite some time. It depends on the type of severity they have. If they are asymptomatic, meaning that they don't develop symptoms, it could remain in the body for a number of days, meaning that they can pass it to somebody else for a number of days. If somebody has mild infection or moderate infection, which means they have pneumonia, but they don't require hospitalization for care, and then you have people who have severe disease or critical disease, which means they need oxygen, they need to be on ventilation, much more advanced care in an intensive care unit. Those individuals, the virus can be in the body for quite a long time. We're trying to measure this in individuals, and we do that through testing. So that's different from how long somebody needs to be quarantined. If I shift my answer to somebody who's been exposed to somebody, so a contact, which means they've been exposed to the virus from somebody who's been infected, but we don't yet know if they're infected themselves. We put them in quarantine for 14 days. And the 14 days is a reflection of the incubation period, which means the time from exposure to the virus to how long it takes for somebody to develop symptoms. On average, that's between 5 or 6 days, but it could go up to 14 days. So we recommend quarantine to be for 14 days. So that's the difference between those two.
Thank you very much, Maria. There are a lot of questions coming up on when is the right time for the person to be tested. Mike just said if you test today, it doesn't mean that there is a guarantee that you're not going to be infected and test positive in a few days. So people are asking, how do they know when is the right time to get tested?
This is a very, very good question, and it's a very difficult one because there's no one specific answer. So as I mentioned, in terms of the incubation period, when somebody develops symptoms, it depends on the policy it's in country. So WHO, we recommend that people are tested if they're in contact when they develop symptoms. If there's the possibility that countries have more testing capacity, they could test contacts who don't develop symptoms, and that could be done on a case-by-case basis. If you have a high exposure, or if you really think that they may actually be a contact and you may want to test, and you have the capacity to do so, then they can be tested. But in terms of when they should be tested after symptom onset, it's usually done after a few days. But what we know is they take an upper respiratory sample, which isn't painful. It's a little bit uncomfortable. I've had the test myself where they kind of go way quite up there in your nasal passage. It doesn't hurt, but it is a little bit awkward. Sometimes you can have a test done and you may be negative, but then they may want to test you again a couple of days later and you could be positive. And so for many people, for many cases, they may have to have repeat testing done.
So viewers are asking, in case they're positive, what is the protocol to be declared COVID-free? After how long time they should test again? And is there a recommendation from WHO how we declare people COVID-free?
So we don't use that phrase COVID-free, but we have different criteria for. The first thing that we recommend is discharge criteria from isolation, which means when do we believe that somebody is no longer infectious? So we have issued some discharge criteria for people if they are symptomatic, and what we recommend is at least, so in the beginning of the pandemic, we recommended that people needed to have 2 negative PCR tests at least 24 hours apart to be considered to be released from isolation. That is very, very challenging to do on a global level. It's very, very challenging to do when we have millions upon millions of cases and when we have testing limitations and when it takes many days to get tests back. So what we've done recently is we've issued discharge criteria without needing a test at the end. And so what our discharge criteria is for a symptomatic patient, we recommend 10 days after symptom onset, plus an additional 3 days of being without fever and without respiratory symptoms. And then they can be released from isolation. For an asymptomatic case, so these are people who test positive but don't develop symptoms, we recommend 10 days from the date that they tested positive, and then they can be released from isolation.
Thank you very much, Maria. Mike, would you like to add something?
No, I think Maria got that one spot on.
There are very few interesting questions going back to contact tracing. Has the WHO issued protocols or best practices on contact tracing apps? And also, is WHO consider developing app? And also a third question is, are we working with some digital companies to standardize those apps that are used in different countries on contact tracing?
So Mike, you want to take this one?
Yeah, no, we are. There is WHO is working with a number of Silicon Valley companies on developing COVID checkers, which will allow countries to adapt a standard app for their use. Because obviously many countries have developed apps, but other countries have not had the resources or the time. So we've worked with companies to develop a kind of a prototype app that then countries can take to adapt their own needs. And this is through the work of both in our program, the Health Information Group, but also the Digital Health Initiative, which is led by Bernardo and Mariano, one of our directors in Geneva. So there's a major collaboration going on to standardize the apps and also provide services to countries who want help with developing those apps. And there is a service there to be able to do that. We also have an increasing number of applications out there for training and for other purposes. There is a WHO information apps out there which information can be got, but we don't do contact tracing at the global level. So WHO does not collect any personalized information on individuals at a global level. It would be not useful. We collect some anonymized information on clinical cases in order to build a picture of those cases and develop therapeutic approaches, but we don't participate in the day-to-day contact tracing. So we support countries in developing those apps when and where they need them. And there's also a much broader collaboration with industry on data management systems for contact tracing. We're working with on a product called Go Data with our partners in the Global Outbreak Alert and Response Network and some industry partners on that. There are a lot of the WHO, we have a training platform, openwho.org, in which we use electronic tools for training over 4 million people now in different aspects of COVID response. And now with the WHO Academy coming online, a much bigger approach to sort of immersive learning and using artificial intelligence and other technologies for both data analysis and for learning applications. So there's a huge collaboration going on. You can speak, Alex, about the work you're doing on myth busting and the social media side of things. So IT has become a huge part, artificial intelligence, a huge part of what we're doing, and applications. But as Maria said before, these are add-ons. These are things that support contact tracing, that support authorities in doing their work. They don't replace. Modeling, artificial intelligence, and apps by themselves don't get rid of COVID. But I think what we're seeing across the board is very interesting innovations that allow us to make what we do in public health much more efficient. And if there are countries out there who still need assistance and want to develop apps, both either for information or for COVID symptom checking or for contact tracing, we stand ready to support them. We currently have a pilot underway, I believe, with Nigeria and with the Nigeria CDC on adapting apps for use at national level, and I believe that will roll out to other countries as needed in the coming weeks and months.
You know, Alex, if I could just add to that, I mean, this pandemic has really forced us to use technology in new ways because we can't travel the way we used to. I mean, WHO, we have country offices in 150 countries, and we have regional offices, and we're here in Geneva in our headquarters, but WHO staff and partners, we tend to travel a lot and do trainings, but we've had to use technology in innovative and interesting ways because of the pandemic. And with the Global Outbreak Alert and Response Network, or GORN, we've actually brought together contact tracing groups and have been having these global consultations about contact tracing. What does it mean? How do we do it? How are countries implementing it? And how are countries implementing it when they're in situations where they have very few cases and when they have overwhelming transmission, when they have community transmission and it's incredibly intense? How can contact tracing be used? How can we creatively roll this out? How do we ramp up the number of contact tracers? And so there's a weekly dialogue that's now continuing to happen to share experiences. And I think one of the things that WHO does, and we tend to do this a lot with our technical networks, where we put clinicians talking to one another, treating patients from all over the world, and actually having them have that one-on-one distinct. We're doing that for contact tracing now, where we're bringing people together to say, this is really, really critical. How are you doing it? What are you learning? How can you help another country? Share your experience, be creative with this, use the tools that are available, but really get those boots on the ground to kind of carry this out. So it's been a great experience of listening and learning from each other on all of these different aspects. And contact tracing is another way we can share this type of information.
Thank you very much. We are running out of time, and we received a lot of questions. So the one that I would like to highlight is, as we're talking about testing for the virus, etc., a lot of our viewers were asking about antibodies testing. What do we know so far? And do we have any new findings about the immunity build for people who already had COVID?
Yeah, so there's different type of testing that is done. The first is the molecular testing, which is testing for an active infection, which looks for the virus part, RNA, so part of the virus in somebody. Another type of testing is looking at antibodies, which is an indication that you had been infected. You have been infected in the past. So it measures your immune response. And so there are a number of studies that are underway. There are a number of antibody tests that are available, hundreds of antibody tests that are available. Some of them perform very well, others don't perform as well. What we understand about immunity, and this is a question we get a lot, and it's a great question because it's really, really critical. For people who are infected with the SARS-CoV-2 virus, this is the virus that causes COVID-19, the name of the disease, people develop an immune response. And this takes days to weeks to develop. And what we are trying to understand is how strong that immune response is in individuals who have asymptomatic infection to people who have severe infection, and how long that immune response lasts. We do not yet have a complete picture of this. There are some studies that are ongoing that are following individuals over time, so cases that had infection and who have had an immune response, and following those individuals month after month after month. And they're measuring those antibody levels over time. And these are really important studies to carry out. So we do see some results coming back of looking at that immune response, and it looks like it in some studies that follow the same individual over time, that immune response stays steady. There are some studies that follow different individuals at different time points. It looks like it may reduce a little bit, but we don't know yet. We don't know exactly how long that immune response lasts. But I don't want to scare people. We want to let people know that, when you are infected, that you will have an immune response. We just don't know how long that will last.
Thank you very much, Maria. Mike, would you like to add something?
Yeah, no, just in between that PCR or that nucleic acid PCR testing and the antibody testing is a thing called antigen testing, which tests for viral proteins. And that's what, in some senses would allow us to, in future, to really bring diagnosis to the bedside or to the home, which is a rapid test that allows antigens of the virus to be detected. They're historically not as good at all as PCR-based testing. They are getting better, and we're working with the agency FIND, we're working with the Global Fund, we're working with the Lab Network, with Mark Perkins' group around the world to really test now how good antigen testing is becoming and seeing how we can use antigen testing with PCR-based testing to do more testing, to bring testing closer to the patient or to the person and the community. So we are beginning to innovate and see how we can use these tests together in sequence to come up with a better framework and a better process of testing. But again, the basis of testing is still testing people with suspected disease with PCR-based testing. And it is very, very effective. It's highly sensitive. It's highly specific. They're very good tests. We just need to do more of them in the right people in order to be able to make progress. But again, we're seeing a huge collaboration amongst labs around the world, between agencies around the world to scale up testing. And when you think that only 7 months ago, we didn't even know what this virus was, and within weeks of that, we moved from not knowing the virus to sequencing the virus to developing tests and to within less than 4 weeks of actually finding out about this disease, we were already distributing reagents around the world in order to make the diagnosis. This is the first, this is the fastest in history. What we need to do now is scale up testing, scale up the availability of testing, and bring together the different types of tests to use them in the most efficient and the most effective way possible. Testing is still at the core of controlling this pandemic, and we need to invest even more in making it more effective, more efficient, especially getting turnaround times down. Getting test results back 3, 4, 5 days after you've been tested it just doesn't work. Those tests are practically useless from a public health point of view. So it's not just doing the testing, it's how quickly, how efficiently testing is done and who is tested. And then does that testing result in a public health action? When someone is tested positive, what happens next? Because I've heard too many stories of people who've been tested positive, go home, they do the right thing, and then 6 days later, nobody has called them, no one has asked them about their contacts, no one has taken any action in result of that. That is a wasted test. A positive test should result in a public health action to respond to that test. That test means that individual has the disease and they may have exposed others. And a positive test result needs to result in public health action. And too often that action is too late because the test is late or doesn't happen at all. And that's a lost opportunity to break chains of transmission and stop this virus.
Thank you very much, Dr. Mike. Thank you very much, Maria. We've been over time for today. I thank you for your efforts and for responding to all these great questions. We'll be in program again next Wednesday, and we'll talk more about mental health considerations during this outbreak. For today, I would like to invite everyone again to join us in celebrating real-life heroes, all these people who are saving our lives, saving our families and loved ones from different health threats. And please keep it with us. Follow our social media channels, our website for more information, and join us next Wednesday.
Continues to spread around the globe. You can help stop COVID-19 by participating in contact tracing. How does contact tracing work? Contact tracing is a system that has been used for decades to stop infectious diseases. A contact is anyone who has had direct physical contact or was within 1 metre for at least 15 minutes with an infected person, even if that person does not have symptoms. This applies to anyone who has had contact from 2 days before a person gets sick until 14 days afterwards, or from the 14 days when an asymptomatic case tested positive. Once you are confirmed as a contact, you will be asked to go into quarantine, which means to separate yourself from others and to monitor your health for any signs of illness. The monitoring ends on the 14th day from your last contact with the person infected with COVID-19. Quarantine can take place in a special facility outside of your home or at home if you can stay separated from family members. Why 14 days of quarantine? It can take from 1 to 14 days from contact with the virus to develop symptoms. During this time, you should stay in quarantine and monitor symptoms and follow instructions given to you if you become symptomatic. Without contact tracing and quarantine, the virus will continue to spread. This leads to more people becoming sick and infecting the most vulnerable. By identifying and limiting contacts of people infected with COVID-19, the virus stops spreading and the community stays safe. To break the chains of transmission, we all need to work together. If you become sick with COVID-19, stay away from others. Follow the recommendations of your medical care provider and share the list of people who you came in close contact with. With your help, we can prevent further spread of the virus and save more people's lives. By acting together, COVID-19 continues to spread around the globe. You can help stop COVID-19